Hello, this is MD4 Dr. Harper. I wanted to talk to you about our new traumatic arrest guideline. It's really a paradigm shift. We're going to be pushing chest compressions further down the algorithm, and we're going to be focusing on the procedures that correct the underlying physiologic derangement that led to the traumatic arrest. All right, those are pretty big, fancy words. What I'm really talking about is stopping bleeding, managing airway, and decompressing a tension pneumothorax. Those three things, if we do procedures focused on those, I think we're going to have a much better approach to our traumatic arrest patients. All right, so let's get into this and let's look at it. So first off, MAR of Marches should be done before chest compressions in traumatic arrest. Think about this. If you're bleeding and you don't have any blood in your heart, what's the point in pushing on the chest? There's almost none. If you don't have an airway and you're not getting any oxygen into your blood, what's the point of pushing on the chest? There's none. If you have a tension pneumothorax and you're having obstructive shock and you can't push blood forward through the circulatory system, what's the point in doing chest compressions? There's none. We need to focus on correcting those three first before we even consider doing chest compressions for our patients. And I think we're going to have a much better approach to how we deal with them. All right, so penetrating traumatic arrest, with or without signs of life, we want MAR and load and go for the patient to a transport to a level 1. As opposed to blunt traumatic arrest, we say perform MAR on scene and call OMD. The reason for that is if you're going to be saved from a traumatic arrest, the studies just show that it's much more likely to be a penetrating mechanism rather than the blunt. We still do have some blunt survivors, so we want to focus our efforts on those physiologic mechanisms leading to death. But the penetrating arrest ones, we really want consideration for a rapid transport. And that doesn't mean you need to rapidly transport everybody. There will obviously be some exceptions, but call OMD early for any type of exceptions. All right. When I say transport rapidly, we mean an ideal scene time of less than 5 minutes. We know that means you're going to be moving, and that seems like a really daunting task. But remember, we're not doing chest compressions on scene right now. We're focusing on procedures, so we're just focusing on those things. So I think that we'll probably be able to get this done. Closed chest compressions / the Lucas are of limited value in traumatic arrest should be de-emphasized. Don't delay procedures focused on correcting the traumatic mechanism leading to the arrest. All right, I think that says it better than I even said it up at the start of this video. Now, when I say do MAR before chest compressions, what I really mean is do MAR and sometimes some of C. I wish I could give you that black and white answer, but the truth is not everything is black and white. There's lots of shades of gray. Every situation's a little bit different. If somebody is truly in hemorrhagic shock and we've stopped bleeding, there might be a really good reason to give blood to that patient before just simply pushing on their chest, because we need to fill the tank, so to speak, so that we can actually circulate some oxygenated blood. So it's okay to focus on blood administration over chest compressions in those hemorrhagic shock patients. Application of the Lucas is to be initiated only after MAR and only when beginning patient transport. The reason for that is the Lucas gets in the way of other procedures. We thought about doing away with the Lucas altogether, but the truth is it's dangerous for you to be doing chest compressions in the back of a moving ambulance, especially while you're running priority 1. So we want you to have the Lucas on while you're doing that for safety for the firefighters and paramedics. Field termination is not allowed without calling OMD unless dead on scene criteria is met. You can refer to page 16 of the general patient care guideline for that. March's protocol is up there on the upper right-hand corner for your memory, and so that for your recollection to know what to do for certain different things. Under that, we included the signs of life. The reason why we included this here is these are things that OMD is going to be looking at when you call us for a termination. These are things that we might want to know. So we've let you know what we might be kind of looking for. All right. So on the EMT, do not start chest compressions until massive bleeding is controlled, airway patency is assured, even if only with BVM, and respirations are addressed for possible tension hemopneumothorax with a minimum of needle decompression bilaterally. The reason why we want you to do those again is those are the things that you're going to do that's actually going to save a life. So focus on them and don't worry about the chest compressions until they're done. If massive bleeding below the diaphragm is suspected, put the IO in the humerus. Easiest way for me to describe this is if the inferior vena cava has a bullet hole through it, there's no point in putting the the IO in the femur and putting blood through it because it's just going to end up in the belly. So if there's massive bleeding below the diaphragm, just go ahead and put the IO in the humerus. Manual chest compressions after the above. Again, the Lucas gets in the way. So if you're doing manual chest compressions on scene and paramedics arrive ready to do their open thoracostomies, they've got easy access to the chest, where if the Lucas is on there, now they have to get that off of the patient. All right, for our paramedics, first under dispatch, it's okay to tell the caller not to perform chest compressions. But what we do want you to do is we want you to focus on March, even with them. Again, every situation is going to be a little bit differently, but we do have some examples here. So stop any hemorrhage. There might be stop the bleed kits around. Military Town, USA, somebody might have a tourniquet, direct pressure, things like that. For airway, you can consider putting the patient in the lateral recovery position. If there's C-spine issues or precautions that you think need to be taken, maybe a jaw thrust. If you do put them in the lateral recovery position, put the injured lung down so that the good lung can fully ventilate and fully expand. Reassess wounds. And then lastly, on H for hypothermia, don't forget they could potentially cover the patient, prevent them from losing warmth while EMS and fire is getting there, so that the patient doesn't become coagulopathic. All right, I mentioned for our penetrating trauma arrest, we want them transported rapidly. There are exceptions. We understand that. If there are exceptions, give us a call and we'll help work through those things. Our ideal scene time will be less than 5 minutes, though. For blunt trauma, work that on scene and then call OMD for transport or termination guidance. Obviously, if Ross, transport immediately. We gave you what we might be looking for in these signs of life up here that might make us say, hey, let's take this blunt patient to the hospital. All right, massive hemorrhage. What I want to point out here is it's probably already done by our first responders and our EMTs, but if not, you can do that. And don't forget about the AAJT for suspected uncontrolled bleeding below the diaphragm. This would be where the AAJT might be valuable. And we put on there below the diaphragm as opposed to below the umbilicus, because what we found is you actually can have some tamponade of like splenic lacerations or liver lacerations from the AAJT, because that intra-abdominal area is a confined space. So it can actually kind of tamponade that bleeding even if it's up above it. So it's okay if you think the bleeding's below the diaphragm, go ahead and do the AAJT if they are in hemorrhagic shock. Airway, advanced airway management here, supraglottic airway if not already done, endotracheal tube, or surgical cricothyrotomy. For respirations, open thoracostomy bilaterally. What we're worried about here is tension physiology, and that can be a tension pneumothorax, but it could also be a tension hemothorax. And while the SPEAR is pretty good, open thoracostomies are much better at relieving tension hemothorax. So open thoracostomies bilaterally in our traumatic arrest patients. All right, circulation. This is where we'll reassess all wounds and then consider whole blood for the trauma arrest patient in hemorrhagic shock. If you don't have whole blood, you can give normal saline. Are there times where you're going to have a traumatic arrest patient with hemorrhagic shock that you're not going to give whole blood because they're in asystole? Absolutely. I wish I could give you a protocol that said do it right here or yes, no, but it's a little bit nuanced. I would say if they have a PEA with a narrow complex over 60, I would definitely consider giving whole blood for that. If you had an ultrasound on scene and you could put that on real quick and you saw cardiac activity, but you didn't feel a pulse, that means that that patient probably just has a super profound blood pressure, and whole blood might just be able to push them back over the edge. Normal saline, even in that case, might be able to push them back over the edge so that they actually will have a blood pressure and a pulse at that point. So consider whole blood. And as I mentioned up above, it's reasonable to consider focusing on whole blood rather than even chest compressions if that heart is likely flat and empty and doesn't have any blood in it. Of course, we got TXA. Don't forget about a pelvic binder if there's any pelvic instability or a blunt mechanism likely to result in a pelvic fracture. And finally, somewhere in here and see, you can start doing chest compressions, either at the beginning or after you've given some blood. And the point of the chest compressions is to circulate the oxygenated blood. If you've given blood back because they were in hemorrhagic shock, now you got some volume, you can circulate that. If they didn't have an airway before and now you're starting to oxygenate the blood, circulating that with a couple of chest compressions is probably pretty reasonable until you get a pulse back. Same thing for a tension pneumothorax. You've restored the normal circulatory system so that they can actually get forward flow of the blood. Lastly, don't forget about hypothermia. It's all about bleeding, right? Hypothermia leads to coagulopathy, which will lead to further bleeding. So minimize heat loss as best as possible. Pausing chest compressions to reassess and redo any of the above is 100% appropriate because, again, those are the physiologic derangements leading to death. So let's focus on really correcting them. So we've told the trauma centers, you might show up to the ER, open the back of the ambulance, and you all are doing a procedure rather than doing chest compressions. That is perfectly reasonable, and all the trauma surgeons are like, yeah, definitely do that. Focus on those procedures that will save a life. And then consider field termination if worked on scene and MAR has been dealt with. We might request transport based upon the specifics of the case. So be sure that you've kind of have those ready or know to look for them. Cardiac motion on ultrasound, if you have an ultrasound available, is really helpful for us. If there's no cardiac motion, we're probably not going to be recommending transport, but if there is, we probably will. All right. Lastly, if you ever have any questions about this, feel free to reach out to the Office of the Medical Director. We are more than happy to talk to you. Dr. Winkler, Dr. Miramontes, and myself have spent a lot of time talking about this, thinking about it, going over it. And we think that right now we are the wind beyond the tip of the spear with regards to traumatic arrest. And we think that this algorithm and this approach is going to be much better than what we've done in the past for our patients. Thank you very much. Have a good day.